If you are doing this, you might be killing your patient. Today, I'm going to talk to you about a serious respiratory condition called status asthmaticus, severe asthma exacerbation, and what not to do so that you don't harm these patients. First off, let's talk about the initial medical management of a patient with severe asthma exacerbation. The first rule is do everything you can to avoid intubation. Intubating a patient with status asthmaticus is a nightmare. So acting beta agonists, continuous albuterol, ipratropium. In these patients, you can give them an hour-long, 2-hour-long continuous nebulizations. Early systemic steroids, IV magnesium sulfate. But what's different in these patients is you can and you should use systemic or parenteral short-acting beta agonist. In this case, we're talking about epinephrine or terbutaline. And these patients are working to breathe, so you should be liberal on the use of BiPAP. So when do you intubate? But despite all these things, it's possible that the patient might still fail and you might have to intubate. When do you make that decision? So altered mental status is the big one. If they start becoming encephalopathic, exhaustion or silent chest, initial rising PaCO2, if the hemodynamic instability. Once the tube is in, the real danger begins. That is ventilator-induced hyperinflation. Why patients with asthma or status asthmaticus die? These patients die not because of hypoxia, but because of air trapping and dynamic hyperinflation. So ventilator mismanagement is a major cause of this problem. But what happens in patients with status asthmaticus or dynamic hyperinflation? So the ventilator delivers a breath here, and then the patient starts to exhale the breath, but because of the severe obstruction, they cannot get the whole tidal volume that was delivered in time. It takes a long time. See how this is scooped, this exhalation curve? Yes, and then before they are able to exhale all the air that was delivered, what happens? The ventilator delivers another breath here, and more air is being trapped and retained in the lungs. And what does this cause? The lungs start to hyperinflate is called dynamic hyperinflation or autopeep. So what is the ventilation strategies that we should use in asthmatic patients? The first goal is to prevent air trapping. It's not to normalize blood gases, and you should accept permissive hypercapnia. The most important thing is you need to keep the respiratory rate low. The next one is the tidal volume. So you should be using a low tidal volume, 6 to 8 mL per kg. The I/E ratio is 1:4 to 1:5. So in these patients who come with acidosis, the reflex is to increase the respiratory rate, increase the tidal volume so that you can increase your minute ventilation, thinking that you would fix the respiratory acidosis. But that is the wrong move in these patients. You got to give them time to exhale. So drop the respiratory rate, use a low tidal volume, and increase the I/E ratio. Deep sedation is required. As I said, you can use either ketamine or propofol. So our target should be a pH of 7.15 to 7.2. That's acceptable.